This ECG has a pretty slow ventricular rate. 1, 2, 3, 4, 5, 6, 7 times 6 gives us a rate of 42. There's a lot of activity going on in between the QRS complexes here. And if we look up here in 2, 3, and F, we do see a negative wave here that looks kind of like sawtooth pattern. And it looks like they are a little bit less than 300 beats per minute. So this is typical atrial flutter with variable AV block. So frequently, atrial flutter is in 2-to-1 block between flutter waves and QRS complexes. In this case, it's more like 1, 2, 3, 4, 5, 6, 7 to 1. So somewhere in the 6 to 7 to 1 range, which makes sense if you divide that into 300. Why might that be? The two primary reasons why you might have AV block at a ratio greater than 2 to 1 is either the patient has some degree of existing AV block, so maybe there was already some first-degree block or some degree of some type of second-degree block, or maybe we've given the patient rate-controlling agents that are causing the ventricular rate to slow down. Oftentimes, flutter does not slow down with medications, but sometimes it does. So this patient may just be on a beta blocker or calcium channel blocker that is effectively slowing the rate down. Axis, up in 1, down in F, up in 2, so a normal axis. Intervals, we don't have a PR interval. The QRS is narrow. The QT looks like it's about 400, so that is probably just fine. There are some non-specific ST T-wave abnormalities, particularly over here in the lateral leads. We see some flat ST segments here, flat T waves, and then in V2, V3, we do see a little bit of ST shift. Now, V2 has got a smiley face concave up pattern to it, and it's really kind of the only lead where we see that type of pattern. V3 has got more of a, it's not really smiley or frowny face pattern here, and it is slightly elevated. But it's not really enough for me to get concerned by itself, unless, of course, this patient also had a clinical story that sounded like an MI, because even non-specific ST wave abnormalities could be representative of ischemia in the right clinical setting. So, why are these like this? It's probably either something called early repolarization, which is a phenomenon where in some people, their ST segment just kind of looks like this. It's elevated and scooped out. It could also be related to left ventricular hypertrophy. This patient does meet criteria for LVH based on AVL and the R wave here being more than 11 small boxes. Or if you add the R wave here to the S wave in V3 is more than 24. So a couple of different criteria for LVH, which can then sometimes give you a variety of non-specific ST and T wave abnormalities. So in conclusion on this tracing, I think what we have is atrial flutter with variable AV block, left ventricular hypertrophy, and non-specific ST T wave abnormalities.